Ladies and gentlemen, welcome to already the third edition of the iPCI Imaging Club, live from the Thorax Center in Rotterdam. My name is Joost Daemen, interventional cardiologist here in the Thorax Center, and today it's a great pleasure to be joined by Jari van Eijk, one of our research fellows focused on intracoronary imaging and physiology. And we have a special guest online also, Jurgen Lichthart, our former colleague who was actually the founding father of a lot of things we did with intracoronary imaging here in Thorax Center. The idea of today is that we'll discuss several cases in which we used imaging, and particular in this edition also CTA-based assessment, including CT-based physiology, to guide PCIs we do in routine practice. The idea is to discuss the case and open up the whole spectrum of steps we took in the procedure for discussion. So we welcome you to join us today and to ask questions in the chat, which we will try to address during the next hour. Jari?
All right, great. Let's start with the case. So we start with a 69-year-old female patient who has been presented to us with stable angina. In her history, she has several risk factors. For example, hypertension, hypercholesterolemia, smoking and diabetes. But she has also a history of peripheral artery disease and a TIA. And because of her risk factors, she has been planned for a CTA. In addition, she has an eGFR of 82 and no abnormalities on the EKG.
Yeah, so this is quite exceptional, and I think you can address to that. So typically we start with a short introduction and we'll start showing you the angiogram, but time is moving. Several decades have passed in which the role of CTA is getting a more prominent place in our routine clinical practice. And also the way we appreciate the CTs, we analyze them, we appreciate the quality that has improved a lot over the last decade, specifically with the introduction of the photon counting scanners we have these days. And we are really trying to really embed all the information we have to make a contemporary treatment plan for our patients. And I think that's why this case is potentially of interest, because we really try to take you through each of the individual steps of workup of this case, and that all started with the CTA.
Indeed. So if we can go to the scan, we can appreciate already like the axial view of this CT scan. This CT scan is made with a photon counting CT scanner here in Erasmus MC. And the first step when appreciating these scans is looking at the quality. Do we see any movement artifacts or stack artifacts? But for this case, that was not the case. So what can we see on the axial view? I already zoomed in for you guys to the location in the aorta where the ostia of both the left main and the RCA are presented. And if we follow, for example, the left main towards the LAD, we can already appreciate some calcium, but also more distally in the LAD we see even more calcium. But it's hard to interpret the luminal narrowing right here on the CT, and therefore these quantitative assessment tools have been developed to further look into.
So what kind of software is this, Jari? So we usually send our cases either to the radiologist who is using VIA or any other, in our case, Siemens applications to the assessment. Then we had a period in which we send our cases to HeartFlow in order to get a better appreciation, at least of the physiological significance of the disease. But do you want to elaborate a little bit on this software?
Yeah, this software is from Pulse Medical, who developed this tool to segment the 3D vessels, the coronary tree, quantitative assessment of the stenosis, and wants to calculate not only the CT FFR, which is possible nowadays, but also to quantify the plaque which is present. Mm-hmm. And I will guide you through the steps which are necessary for this analysis. So first of all, we go to the vessel step, in which we can see which center line it has detected through all the vessels. And it segments the coronary vessels as well as the side branches. And it has a nice 3D modeling of the heart. If we go to the next step, based on the center line, the luminal contouring and the media contouring is found. which can be appreciated not only in the cross-sectional views, but also in a longitudinal view. And if we zoom in, we can appreciate the calcium in the mid-LAD right here. And dependent on the contrast settings you use, you can either see a lot of the blooming artifacts, or we can, when we reduce the blooming artifact by increasing the contrast level, we can more accurately see the lumen contouring.
Yeah, and yeah, is this all done automatically, or was there a lot of manual processing needed in order to get these nice images and also the quantitative reconstructions?
Indeed, good question. So this center line detection is performed automatically. Each step is performed automatically, but to ensure full quality, we allowed manual corrections in case there were large discrepancies present. So right here you can already see, also in the bottom, we can see the luminal profile of the diameter across the longitudinal vessel. And in the next step of stenosis, we can appreciate the luminal diameter, and it calculates where the stenosis are present. For example, for the LAD, the calcified lesion right here has been detected automatically by certain borders as well, based on the reference line, which is a stepwise approach based on the proximal and distal reference. Based on this reference, stenosis is calculated, and stenosis above 25% are detected as lesions. And on top of that, a plaque parameter is visualized right here, in which you can appreciate the amount of calcium with a lot of quantitative numbers, and also a stenosis analysis has been performed right here. So, for example, here in the LAD, we see a diameter stenosis of 35% with an MLD of 1.63.
So that's quite small, right? An approximate LAD, a minimum lumen diameter of 1.6. But still, that corresponds to an area of 209. Is at the side of the smallest area, so to say.
Indeed.
Yeah.
So that's for the LAD. We have calculated, based on this stenosis, we can calculate the CT FFR, which is an estimation of the FFR measurement as physiology guiding your treatment decision. So right here, the CT FFR is indeed dropping at the lesion, but also there's some diffuse disease distal in the LAD, which eventually measures a CT FFR of 0.77 right here, or 0.76, where you would measure your FFR as well.
Yeah. So in summary, tight calcific plaque with a area stenosis of almost 60%, minimum lumen area of about 2, and approximate LAD, concentric calcifications, right? If you scroll through the scan, and what is really helpful in the CT scan, at least what I appreciate the most, are not the specific individual numbers, but the morphology of the lesion, the amount of the calcium, the eccentricity of the calcium. Here there you see both very thick eccentric calcium as well as concentric calcium, and you can very nicely appreciate how this lesion extends into major side branches or bifurcations. For instance, here, Jari, if you would make a guess, suppose this lesion indeed is angiographically and physiologically, when confirmed invasively, tight and significant, would there be a need to go into the left main with the stent, or do you see any let's say, quote unquote, healthy references in the proximal part of the LAD?
I would say there may be a little bit of healthy reference before the left main.
Okay.
So right here,
but that's not a little bit, right? I mean, if you look here, this is the proximal LAD. So look in the panel, the middle panel on the left, you see a little bit of eccentric calcifications, but actually the lumen looks quite nice. Here as well, you see basically very limited amount of plaque. So likely yes, right? And the left main looks good, is that correct?
The left main, there are some calcifications.
Yeah.
But
spotty ones.
Spotty ones.
Yeah. Okay, very good.
Yeah.
So LAD tight calcific lesion, FFR or CT-based FFR 0.76. What about the right and the circumflex?
Indeed. So let's go to the circumflex. In the circumflex, there's also some calcific lesions. If we look into the plaque feature, we have a proximal with the bifurcation of the With the bifurcation of the LAD, we have some calcific spots, but also a calcific lesion proximal. And at the bifurcation with the obtuse marginal, there's also some calcific disease. If we look at the diameter, the reference line is adjusted by the side branches, and thus it doesn't detect any significant stenosis proximally. Also not distally with the side branch with the OM, but there is some mild disease.
So spotty calcifications, but no clear narrowing. There's a question in the meantime. I'll maybe broaden the question a little bit to more generically on the scanning protocol. One of our colleagues online is asking whether we use adenosine for the CT scan. Do you want to comment?
Yeah, we're not using adenosine for the CT scan, but we try to make the CT scan of a good enough quality, and what helps in this case would to lower the heart rate with some medication. So yeah.
Yeah, so I think that's a good point. So we now have the luxury of having two photon counting CT scanners in Erasmus, which we thought, well, this is going to be a game changer. And in all fairness, the image quality we get with the photon counting scanners is absolutely better as compared to the initial energy detectors. But yet the quality of the CT scan depends partly on the scanner per se, but perhaps even in greater extent on the scanning protocol and proper patient preparation. So a low heart rate and nitrates before the scan are absolutely crucial in order to get the best quality scans, because a patient with AFib, high irregular heart rates, no nitrates, scanning in false phases really will not allow you to get good quality reconstruction of vessels of 2 to 3 millimeters in diameter. So that I think is very important. With respect to the adenosine, so this software platform uses a sort of a simplified computational fluid dynamical model, in this case a Murray law-based model, in which the flow across a specific lesion is estimated based on several laws from fluid resistant and viscous resistance of blood, and the Murray law concept, in which all the side branches are taken into account in order to estimate the decrease in flow and pressure across different bifurcations. So that's how the software works. So it estimates the increase in flow in terms of, let's say, assumed hyperemia, but there's actually no need to actually give adenosine or other hyperemic agents during the CT scan, and of course also not during the reconstruction. So maybe that answers the question.
All right.
So we had the circ, the right,
Yeah,
before we continue to our more familiar images on angio and intravascular imaging.
So if we appreciate the RCA from proximal to distal, we can again see some spotty calcifications right here in the proximal RCA, but more distal. There may be some calcifications as well, and at the location where the RPD is side branching, we see some calcifications as well. But eventually, the CT FFR right here will not be significant by the spotty calcification. So
yeah, and I think we also need to be fair that here we are very distal in the posterior descending artery. The system measures the diameter of 0.9. Obviously, this is where, I mean, the CT is perhaps still a bit hampered by the vessel caliber, but at least in the larger segments of the right, the vessel looks to be nice and patent. So a lot of information from the CT scans. We know upfront a little bit already what to expect, because this patient is obviously already a little bit further as to what the guidelines recommend. So guidelines currently recommend to use CT basically mainly as a rule-out technology for patients with low to intermediate risk disease. But this patient, did you calculate a risk score for this patient, Jari?
yeah, I did. So based on the risk factors itself, the risk would only be 90%. But with the additional peripheral artery disease and TIA, you can adjust these weights to have a little bit of a higher estimate of the a priori chance.
Yeah. Yeah, so low to intermediate risk, but I mean, this is how we use CTs these days. A lot of sites are using CT not just to rule out disease, but also to define treatment plans, and that's where also now a lot of studies obviously are focused on in order to see if there is a role for CT to guide PCI and to stratify patients upfront based on the more extensive assessment of CTA. Anyway, enough of the CT for now. Let's proceed with the case. So we obviously, with these findings and typical symptoms and the risk profile, took this patient to the cath lab. And what did we see, Jari?
Yeah, we see the RCA in two different projections. There's not too much luminal narrowing, but you can maybe appreciate an intermediate stenosis at the side branch at the RPD.
Yeah, so very distal in the PD. There seems to be an intermediate lesion, which we already knew based on the CT, with a spotty calcification, but no clear focal significant disease, at least in the proximal to mid part of the right.
Indeed. If we continue to the left tree, we can appreciate the spider view in the left. We see the proximal LAD going upwards. Without the contrast, you can already see some calcifications in the mid LAD right there. And you can also appreciate the circumflex already. So in the spider view, it's not that clear, but if you see the caudal view, indeed at the bifurcation with the OM, there is some mild disease. If we continue to the LAD, we can indeed see in the mid LAD there's some stenosis there, some intermediate disease, which I would be likely to treat. But what are your thoughts? And based on your your experience, what would your strategy be?
Yeah, I mean, this is a patient with stable coronary artery disease, typical symptoms, refractory to conventional medical therapy. We didn't go into details on what the patient was using, but assuming he was treated optimally medically, there is a clearly calcified intermediate lesion of, let's say, 50 to 70% in the proximal LAD, which I think per current guideline recommendation would be a class 1A recommendation to use intracoronary physiology. But obviously here we're a little bit biased because we have the CT up front, which already demonstrated that this lesion was first tight, second severely calcified, and third also physiologically significant based on the CTA. Mm-hmm. I don't know what people online think, but yeah, I mean, we use the CT more often, but with all these new indices, and I mean, this is the CTA-based algorithm of Pulse Medical, which has been validated in China, showing a very good correlation to conventional pressure wire-based FFR. But yet, large-scale Western validation trials on using this CT-based physiology to guide contemporary PCI are lacking. So that's why, at least here in Rotterdam, we still like to confirm the findings with the more conventional measurements, and that's exactly what we did here.
Yes. So indeed, the CT MUFR was 0.76. So what we did in our center is we performed a angiography-derived VFFR, which estimates your VFFR or estimates the FFR value based on two angiographic projections without the use of hyperemia or pressure wire. So based on these two projections and the contouring of the vessel, a 3D model is created. And well, again, based on some mathematical formulas, the VFFR was estimated to 0.77.
And it's interesting to know, Jari, and I don't think you're going to mention this, but this is actually the software that we recently validated in the FAST-3 trial, which was presented just last month at ACC with a simultaneous publication in the New England. So this now is likely to be going to be one of the accepted alternatives to conventional pressure wire-based physiology in patients with intermediate coronary artery lesions. So just as a small note and a little bit of marketing for the work we did with a lot of highly involved co-investigators within Europe.
Yes. And just to be sure, we did an additional FFR value, which turned out to be 0.79, which is significant because it's below the 0.8. Even the RFR was measured, which was 0.88. But maybe the pressure wire-based physiology may have been a little bit hampered by a little bit of bridging in the mid-LAD.
Yeah. Yeah. So a lot of you guys would question, well, aren't you exaggerating here? You have the CT-based physiology, you have angio-based physiology, then you do a resting index with RFR, then you do a pressure wire-based physiology. At some point, yes, you may be right, but I think at this stage we are still learning. Within our lab, we only implemented the let's say, a more routine use of angio-based physiology after the results of the trial a couple of weeks ago, in which we have still a low threshold to use the pressure wire also for reimbursement reasons and so on. So in that perspective, you could argue what to do within a year from now, in which you may just rely on one of these indices. But I think this is just to demonstrate you that the CT, the angio-based physiology, and the conventional FFR are almost identical in this case, which at least to us every time again really keeps confirming that if the image quality is good and you feel comfortable with the assessment, then you really can rely on image-based physiology as an alternative to the conventional pressure wire. That said, we were convinced now this lesion was positive. We knew about the from the CT, this was a heavy calcified lesion, and that's where we went ahead with PCI. So, Jari, do you want to take us through the procedure?
Yeah, so we started off with a pre-PCI IVUS of the LAD. And as you can appreciate in the IVUS view, we go from distal to proximal, from left to right. We can already appreciate the lumen and the media, and even more, so you can already nicely see where there is disease. So right here, we can identify the calcium already. And even more calcium will be here a little bit further at the MLA right here, with a plaque burden of estimated 80%, and going more proximal, we're getting back in a more healthy vessel. Right here.
Yeah. So this is interesting, right? So you have the, maybe we can take you guys back to the imaging. So what is interesting is that indeed my question with the osteo-LAD is answered, right? So in the proximal part of the LAD, if you can show us, Jari, there's basically, there's a small chunk of, but this is the left main, right?
Left main,
so here you see the bifurcation. If you go to the right, you see the bifurcation. Don't go too fast, people cannot follow you. Okay. And then you see the double barrel. Whoppa, there we are. So the circumflex going down at 5 or let's say 7 o'clock, and here we are in the proximal LAD, which is a very nice and largely calibrated vessel. And also, for those of you who paid close attention, the area on the CT scan was estimated to be about 7 to 8 square millimeters, and that's where we consistently see significant discrepancies in between the areas measured by the CT and the areas we find invasively with intravascular imaging. So remember, area in the proximal LAD of about 7 on the CT, but on IVUS you see that the area here is almost 12, where the vessel is somewhat more healthy, which fits with the caliber of a proximal LAD in a male patient with a diameter above about 4 millimeters. But what you can also appreciate is that the calcifications on CT are clearly confirmed on IVUS. But I would say, based on the IVUS itself, yes, there is calcifications, but there are nowhere truly concentric calcifications. It's mainly eccentric. And I would not be really worried here that I would have any problems by getting proper stent expansion based on the amount of calcium I see here, except for this small spot in which the lumen area obviously is small. Any comments from the people online? Jurgen, maybe your insights here? Welcome, thanks for joining.
Hi, thank you, Joost, and it's nice to be here, a little bit back in business. Well, what I see you mentioned, there's no concentric calcium, but I would correct that in hardly concentric calcium. There's a very short spot of, and what I did also not see is any reverberation after the calcium. That means, and that you could also see that already on the CT scan, that also on this concentric spot near the side branches, that you can have a rather thick plaque of calcium that can give some serious resistance. So for me, I would say that to try at least to prepare this lesion and then check again with the IVUS if it did work.
Yeah, very, very fair point, Jurgen, well taken. If you can show the IVUS again, so this is the spot that Jurgen is referring to. So indeed, there is a thick calcification. So what you indeed cannot see is any reverberations, which is a sign of thick calcium. But that's what we already knew from the CT. So, I mean, there's no argue that this calcium is likely relatively thick. But the length of the segment where the calcium is nearly concentric is very short. So here we see signal penetration. So here I'm at 40 millimeters. I go a little bit different, and here again signal penetration. So the length of this ring is 1 to 2 millimeters, and we know if it's less than 5. I think Jurgen and I, we typically are on the same page. Obviously, clearly you need to do the lesion preparation, but I mean, not necessarily immediately with a shockwave balloon or a cutting balloon.
No.
I think this with these criteria, I think we would be good with a NC balloon to start. But then, and that's a very important point Jurgen just made, recheck the result of the balloon with a second IVUS run. Not sure what happened here, but we'll show you in a second. In the meantime, there is a question, Jari. Let me go back to the question here. Variability of CT-based FFR. What do you think? You look for, actually we know the answer because you just did a validation study with the photon counting scan, intra-observer variability and inter-observer variability with the CT.
Yeah, so for the intra-observer variability, we found an intra-class correlation coefficient of like 0.92.
Yeah,
but,
so very good.
For among various operators, the inter-observer variability was found to be moderately around 0.72.
Yeah. So, not perfect, but at least moderate to good. But obviously also, again, depending on the scanning frequency and the amount of corrections you do with the center line, lumen, and importantly, the proximal to and distal normal references to be used to get the physiology. So, yes. Pretty good, but you're right. There's obviously more variability as compared to a conventional pressure wire or even angio-based physiology.
Definitely.
One more question. Sizing and planning. Okay, let's get back to that in a second. Could improve the quantitative plaque assessment and more precise calcium. Yeah, so whether this more precise assessment leads to better stent sizing and positioning, likely yes, but to us it's more like stratifying the case up front and then confirming with intravascular imaging, specifically because, and that's my personal opinion, intravascular imaging allows you to do everything from top to bottom. It allows you to scan the disease severity up front, as we just did, but it also allows you to check for the post-PCI result, which obviously the CT scan cannot do. So that's where I think there is a mutual benefit of doing both the screening with the CT and then using the intravascular imaging to guide your PCI. Pre-procedure, post-lesion prep, but also importantly to check the final result. Okay, in the interest of time, let's proceed. So we did our pre-PCI assessment. You see, we didn't do any real measurements at this stage, and why not, Jari? So a lot of people would start sizing a stent, but Jurgen already gave the answer partly, and I think you can address to why we didn't do that or why we would recommend not to do that.
Yeah, so we're first going to do some lesion preparation. And after lesion preparation, we will do another IVUS to confirm if the calcium has been cracked. Yeah. And then we can size our stent accordingly.
Yeah, because obviously the risk of dilating these calcified plaques is that the vessel might tear apart, you get dissections, you get hematoma, which will definitely make that your landing zones will change. Yeah. So doing a lot of sizing on the first pullback actually, at least to me, doesn't make a lot of sense if you at least already know upfront you're going to do some lesion prep. Yeah. It saves time.
Definitely.
All right, if we go to the slides again, we can appreciate the next step in which we performed a pre-dilatation with a non-compliant balloon of 2.5 millimeters.
So not too aggressive, right? The 2.5, we know the proximal LAD is 4.0.
And now, directly after we did another run of IVUS indeed for the sizing of the stent.
And to see if the calcium was fractured.
Yes.
So remember, MLA 2.9 in the tightest part of the LAD. So what happened, Jari? So we have a pullback now after the lesion prep. We gave some nitrates, importantly.
Yeah. So again, in the second IVUS run, we can appreciate from distal to proximal. Right here, there's...
Can you show the IVUS?
Right.
Yeah, thank you guys.
Right here, from distal to proximal, we go...
So what is nice, Jari, about the first frame in this pullback?
It's a healthy reference.
Yeah, and that's important because the first, I always recommend to start your pullback in a healthy reference segment. And it's not that difficult to do so because you can use live imaging to advance the coronary. But you can also just switch on live view before you start the pullback. And if the first image you get is a healthy reference segment, that will allow you to measure whatever you want in this segment of interest. So never start the pullback in the middle of the plug.
Right. If we advance further proximal, we can indeed see the calcium. But of most interest will be the most eccentric lesion right here, in which we can see some calcium cracks.
Yeah, definitely.
And then going more proximal.
At 11, yeah.
Yeah, so Jurgen, as you were online, why do you say definitely? Because a lot of people will say, yeah,
if
well,
you go,
okay, but...
Can you go to the smallest spot?
Yes,
and then,
we can.
Yes, yeah, there it is. You see at 11 o'clock, 10, 11 o'clock, you see a crack there. What wasn't there before. You see this part, I put now with my mouse, but you can't see that. but you see that crack in there. And before, on the pre-IVUS, you saw it actually the whole calcium concentric. Now, with this in mind, I think you're safe now that you can deploy your stent completely because this calcium will give way like clamshells. And just to have a question what was earlier asked, a couple of years ago, how many cracks do you need? Actually, as far what I saw in all the cases, only one clear crack is sufficient.
Yeah. Yeah, and that's I totally agree, Jurgen. And people who do not see the cracks, do not worry. But what always helps, in my opinion, I mean, if you see signal penetration here and here and here, you know the calcium is no longer concentric, so that's all you need. So if you see signal penetration at multiple angles within the cross section, then you know that your calcium is at least no longer concentric, and it usually yields when you scaffold this with the stent with a sufficient amount of radial force. One more thing I wanted to mention, but I forgot actually. I was confused by the question. Anyway, so two things. So one was the calcium. MLA is still small, but we already alluded to the fact that the calcium seems to be fractured. But there's one more thing, Jari, because we looked at the lesion, but now, and I'm curious to see what you're going to do with the stent sizing. So maybe you can take us through what you would do to size a stent here.
Yeah.
So this is the Avigo software of Boston, which allows you to put the blue borders where you think the vessel is healthy, meaning the plaque burden is less than 50%. So based on that, Jari, what would you do?
Yeah, first of all, I would search for a healthy reference distally. So here we can still see some calcified plaque, but here it becomes quite healthy, but there's more plaque right here. So
it's actually a tandem lesion, right? So you have the calcium, the calcific lesion proximal, but then also distally, and the system gives you the min. You see where the system says min. That's where the system finds its minimal lumen area. So here is a plaque with a plaque burden of 75%, which is actually a little bit distal to the side that we focused on with the calcium.
Yeah. So right here we have a plaque burden of approximately 41%.
Would do the trick.
And we're going to more proximal to the concentric lesion or the eccentric lesion.
Yeah, we need to cover that.
We have to cover that, and approximately here it's the plaque burden is again under the 50%. So I would pick approximately here as a proximal landing zone.
Yeah, and the diameter here is about 4.0, so in yellow the lumen dimensions, in blue the EM dimensions. Yeah,
mention one thing. Can I mention one thing, Joost?
Obviously.
Yeah, if you go directly, because I noticed something also on the IVUS, and that was exactly a demonstration that you already mentioned, that your landing zones could be changed. If you go directly, you see that the vessel is also dissected after this pre-dilatation. And you see, if you go a little bit, over here, you see, at 12 o'clock, you see a flap, and with a darker spot around that. So that's part of a dissection, and that is probably an integrated dissection created after the pre-dilatation of this calcified lesion. So you found already, you passed already the dissection with your landing zone, so that was okay. But in this case, in other cases, this could have been, if you look at the pre-IVUS, your good landing zone with less than 50% plaque burden, but that could change immediately. That could change after your pre-dilatation. You see, and that's why it's so important to check this.
Yeah, absolutely. So if you just click on the between brackets, you get your length. People will ask, what kind of stent would you use? Jari, diameters, what would you recommend here? So there's a huge discrepancy, right? So this is 26 millimeters. Proximally, we have a vessel of 4.0. Here we have the diagonal. Here's another diagonal. And then here we have the distal, or let's say mid-LAD, with the area 4.3. So what do you think is reasonable?
Well, to size your stent, you're looking at the distal reference, and we're looking at the media area, or the media diameters.
The plaque burden is low, which is the case.
So right now we can appreciate a 2.84 and 3.17 millimeter distal reference. And as I've learned, well, then you should pick a little bit smaller than the largest diameter you find. So I would go for a 3.0 and then 26 stent.
Yeah, so 3.0 could be good, but you need to be careful here, because you would like to have a stent that has expansion limits that at least go up to, I would say, 4.0 proximally.
Yeah, indeed.
All right.
So if we go back to the slides, we can appreciate the next steps. So what we see right now is that we performed indeed an Orsiro drug-eluting stent of 3.0 with a 26 millimeter length right here. And we did a post-dilatation distally with a 3 millimeter and more proximal a 3.5 millimeter non-compliant balloon. And to appreciate the results, again, we did an IVUS run. So let's look at the second, the third IVUS run.
And if you think what we just discussed, what do you think about the strategy? So the 3.0 stent we predicted, the length 26 is in line, but then we post-dilated. We tend to routinely do that these days. In case there's calcium, we routinely post-dilate before we do the post-PCI pullback. In my opinion, that makes a lot of sense, saves time, and you per definition get better stent areas. But the 3.5 strikes me a little bit. Shouldn't have we taken a 4? Wouldn't it have been better to take a 4.0 based on what we assessed?
We indeed measured a proximal diameter of approximately 4.0. So it could have made sense, but I think the 3.5 non-compliant balloon you can overinflate a little bit.
Well, the non-compliant is 3.5, right? So that will not get bigger than 3.5.
Okay.
But yeah, it's just a small note. In retrospect, you think, well, okay. But let's see. We can, the correct answer would have been you can always go bigger at the end. Going smaller is more difficult.
True.
All right. So post-PCI IVUS.
Yeah. So again, from distal we go proximally. You can see a small side branch. There's some. Here start the stent. We do not see any stent dissections. We go a little bit further.
Yeah.
We measure an MSA of approximately 5.5 right here, where with the bifurcation with the diagonal, and more proximal. We do not see a stent or a dissection or at the proximal side.
Yeah, so the stent landed relatively distal, so we didn't really land the stent in the proximal part where the vessel is 4-0, so it landed just, let's say, in the neck of the plug. But this actually doesn't look too bad. This is very typical. I mean, to find a stent area, you would expect a stent area of about 6 to 7 with a trio stent. But here the minimal stent area is, at least the minimal area at the site where the tightest lesion was about 5.6, which is not too bad. Everything above 5.5 we consider to be reasonable. And remember, this is after high pressure post dilatation with a 3.5 balloon already. So yeah, this is what you get, and whether this will really improve if you would have pre-dilated this lesion with a shockwave or a Wolverine is currently not supported by evidence. The trials we have today show that there's basically no significant difference between each of the individual strategies. But yeah, conceptually, sometimes if you don't have good results with the NC balloon, there's definitely a lot of cases that we see in routine practice in which more aggressive lesion preparation may help in order to get better stent areas. There is a question, Jari, what to do. So this case was relatively straightforward because of distal sizing, because the vessel is relatively healthy here. But what would you recommend to do in case there is more diffuse disease? How would you size your stent? I think I would answer the question very pragmatically. You said, okay, distally I want to size based on the media, but now suppose, and I mean this is not a good example, but let's for instance take pullback number 2 and suppose that this would be your best reference area. How would you size your stent? Because here the discussion is obviously a little bit different because the plug burden is much higher here. What would you recommend to do?
Perhaps you can consider a 2-stent strategy.
That's a very good suggestion. Yeah, so a smaller stent distal, a larger stent proximal. Other suggestions?
No, not come up right now.
Yeah, so I think the point, and I think Jurgen, we had this discussion many times, and that's a discussion on how do you size your stent.
Yeah, I know. My first answer is always then because this can be very common, especially in diabetic patients. So it's a very good question, and the answer is to be practical. First of all, you step back. And then you know that you realize you're not a cosmetic surgeon, but an interventional cardiologist. Yeah, that you have to realize first. And what I always do, that the interventional cardiologist knows his patient and he knows what size of vessel, what size of lumen his patient needs to get rid of the complaints. And I'm always very pragmatic because I size always a spot of the lumen where you want to land, where you decide to land, and then calculate this size that you make it rounded up to above. Measure the lumen and then round it up to above. But you decide the spot where it is and what size your patient needs to get rid of his or her complaints. That's the pragmatic thing. And all this and it's good that I can mention this. I hear a lot in publications and things that people try to go lumen media to media, do all kind of calculations in there and forgetting about remodeling, etc. Just take the lumen and go and round it up above, and there is your stent size. But then remember that you need to look at your patient, who is he or she, and then you can define what does this patient need.
Yeah, and in that perspective, I totally agree. Use your common sense. I mean, the LAD is usually about 10 centimeters in length, and if we're looking here at the first 3-4 centimeter. But if you know that at centimeter 5, 6, and 7, the mean area is let's say 4 or 3 to 4, it doesn't make any sense at centimeter 3 to make it 8.
No.
Because that is the outflow. Everything is 4 to 5, so you can make it 8 and dissect the whole thing because you land your stent in the middle of a plug. But that doesn't make any sense. So be pragmatic. That's why I think the whole discussion on potentially using DCB to be a little bit more kind and not scaffolding everything could make sense, but also that needs more evidence to support that concept. But use your common sense and stand what is needed, but don't try to make it cosmetically beautiful and then land it in an area with a area of 2 to 3, which doesn't make any sense.
And this was, by the way, this picture here shows a perfect. Oh yeah, that. I saw a beautiful. Beautiful. Very good submedial dissection of hematoma. That was a couple of pictures proximal. It was the picture. Yeah, here it is. You see a little bit distal, a little bit distal. Yeah, there it is. You see a little bit more proximal, Jari. Please. Yeah, that's it. You see the media is going there. It's broken even. And then you see behind the media, you see the hematoma of this dissection. Very nice picture, by the way. Yeah.
Jurgen, you see, we still have nice images. They keep coming. The difficulty is to appreciate the beauty.
I didn't expect less, Joost.
Okay, good. So in the interest of time, so we proceeded the post-PCI pullback we just discussed. So in brief, do this systematically. Distal stent edge, Jari. 2 things we look at.
Dissections.
Dissections, do we see dissections distally? No. We see a plaque burden less than 50%?
Less than 50%, yes.
Okay, so Jurgen and I spent many hours in drawing contours with our fingers, with the mouse, to calculate the plaque burden, but that's where I think this new AI-supported platforms make a huge difference. Everything is done automatically, and it's actually very accurate, I have to say. So no need to measure anything. Your system gives you the measurements instantaneously. Plaque burden less than 50%, check. Minimal stent area instantaneously. If you put the markers on the stent edge, you get your area. So in this case, the minimal stent area, it's very typical distal, is 5.3. Proximal stent edge, same thing. No dissections, plaque burden below 50%. We're happy.
Yeah.
All right. Good. What happened?
Let's go to the next slide.
Final angio. Nice result.
Yeah.
But then there's one more thing.
Indeed. What are we gonna do with the diagonals?
Yeah. So the diagonal is pinched. So there are 2 larger diagonals. This is obviously something that is open for debate. Do you want to embark in complex bifurcation stenting in this calcific bifurcation lesion, which we know, which is now also jailed? People in the audience, anybody who wants to comment? Somebody already mentioned if there's diffuse block and no good landing zone, can we use DCB? You can always use DCB. But whether that is better than doing nothing, that I think remains to be proven. For the diagonal, I think similar discussion. We consider this to be a significant branch, so patient was stable. We wired it, opened the struts with the 2O balloon. And then there you have your DCB. So here I would definitely refrain from additional stents. But this is nice. So the reason we're showing you this is that the diagonal had a TME2 flow. We pre-dilated, we used the DCB, and then we thought, okay, this is it. This is all we can do. We did a kiss here, you see the 2 balloons, and then we thought we'll go home. But then we still had the IVUS catheter, and I would really encourage everybody to consider using imaging again also after the DCB, or at least after the lesion prep before the DCB, because this gives you so much information on how you send your patient home, because you knew up front that the MLA of this, so the minimal lumen area and the diagonal up front was very small up front, but whether that increased from 1.5 to 1.7 or from 1.5 to 4 after your lesion prep or DCB, the angio will not tell you. But prognostically for the patient, obviously conceptually, it makes a lot of sense. Whether you increase your area from this to this, or from this to this. And that's what the IVUS will tell you. So you get a better appreciation of what you actually do with, for instance, DC being diffuse disease. If you don't look, you don't know, and you will never learn. So that's, I think, why this case is interesting. So what happened here?
So we did the post-DCB IVUS, but before we go to the IVUS, I want to ask you, why not make an angiography first? or how the flow is right after the DCB.
Absolutely. So two things. Per every current guideline on the use of DCB, you should make an angio before doing a DCB. Just to confirm T-3 flow, absence of large flow limiting dissections, and preferentially a diameter stenosis less than 30%. In this case, we gave a small puff. We were very pragmatic, didn't use a lot of contrast and additional radiation, but were a little bit aggressive by immediately using a DCB. Also because two reasons. One, we were definitely not going to implant a stent in this lesion. And the second reason is that we learned, and that's data that has been recently presented also at CRT, the luminal area increases, of course, after lesion prep, but increases even further after DCB with about 0.5 square millimeters. So that's something we learned by doing these type of imaging analysis, and that's where we're, specifically in lesions that we would not stent anyway, continued immediately with the DCB. Does that answer the question?
Yeah. I'm really wondering how the angiography results will be.
Yeah, and then there is a question whether the IVUS is going to affect the drug applied to the vessel. That's a fair question that has been, let's say, asked in many meetings and many times before. Obviously, I do not know the exact answer. I mean, if you envisage that the IVUS catheter has a diameter of 1 millimeter and this diagonal is 2.5, the drug is disseminated into the plug. I don't think it does a lot of harm, but I don't know the answer for sure, of course. All right.
Let's go to the IVUS image of the diagonal.
Yeah, so we did an IVUS indeed.
Indeed. Well, again, from distal to proximal, we see a healthy reference distally.
It's quite interesting, right? I mean, this diagonal really looked quite small on the last angio, but if you did the IVUS, you see the vessel is at least 2.5 in caliber. Yeah. And completely healthy. So what do you see at 3 o'clock, Jari? What is that?
I think it's the myocardium. No, sorry. No, I'm a bit.
The vein?
The vein.
The vein, right? It's a round structure, and it doesn't look like a muscle. So it looks like there is blood in there. You see, it has the same signal intensity as compared to the coronary. Yeah. So this is a vein.
All right.
You see even a bifurcation in the vein.
Yeah,
there it is.
Yeah. All right.
And if we appreciate the lumen of the diagonal, we see some calcification.
How would you classify this plaque, Jari, if you go a little bit more distal? So for the people online, 3 types of plaque: lipidic, fibrotic, and calcific.
Well, we see bright contrast right here with reverberations. Yeah, so that will be a little bit of thin calcium, but the rest of the plaque, I would think it's fibrotic plaque.
Yeah, so if you go a little bit more, so indeed there's a little bit of calcium. You see the signal attenuation, and here this is nice. You see a plaque with a signal intensity completely similar to the periaphantational space, which means this is fibrotic tissue.
All right.
Voila.
It's a good bifurcation.
So you're going quite fast, Jari?
Sorry.
Any comments?
It's a very good bifurcation. Yeah.
So what do we see?
Right here, we're at the bifurcation between the diagonal and the LAD.
Yeah, so this is what we call the area of confluence. So what do you see at 4 o'clock? You see the wire coming in?
Yes.
Or the wire going out, actually, from the stent into the diagonal. But how does this lesion look after the lesion prep? Are you happy? Happy with this ballooning?
Yeah. I think the lumen has increased.
Yeah, I mean, we didn't do a pre-PCI IVUS, so how much it increased we don't know, but at least we know how we send the patient home. And here I like to look at the distal reference area. So this is about 4. So where the vessel is healthy and is regular shape, 1 centimeter more distal, the area is 4. So that's your reference in terms of what to expect a little bit more proximal. Here you see that the vessel area is 3.3. Here's some eccentric plaque. Yes. And then if you go to the area where we did the ballooning, it actually looks quite good. It looks actually very good. So the area here is about 2.9, 3.4. No, I mean, there are some dissections maybe here.
Small ones. At 9 o'clock also, a little bit, a very tiny one.
A very tiny one at 9
o'clock. Yeah, at 9 o'clock at near the osteum.
Ah, more proximal,
there you see?
I didn't.
Yeah, see?
Yeah. Yeah, but this actually looks good, right? So I think we definitely improved here. If you look at the imaging plus, which you can see, and this is how a bifurcation should look like. So here we are in the LAD, a little bit more proximal, in the calcific area, and this is where we are in the side branch. So no overhanging struts, everything looks nice and patent. And that's actually the result you would like to see after bifurcation treatment. Whereas you know that after bifurcation stenting, for those of you who do imaging in bifurcations, you rarely find this. How good you are in doing culotte, decay crush, top stenting, you always have struts that are squeezed into one direction and let's say hamper the flow in the ostium, at least rheologically. So no, I think this is looks really nice. All right, good.
So if we go back to the slides, we can appreciate the final angiography. And I think that looks very nice.
Yeah, looks very good. So I think this brings us to the end of this case.
Yeah, we have another case, but
I think we have a couple of minutes left. Are there any people with questions online? Questions, things you may want to know, or you want to see, or you want us to explain with respect to this case?
Fibrocalcific indeed.
Yeah, the plaque was fibrocalcific. Let's see. Post-DCB, how much lumen gain is sufficient to have good results on imaging? That's obviously the key question. So the only cutoff I would say we have is a diameter stenosis less than 30% after lesion prep. Usually you may be able to achieve that in 60 to 70% of the cases, I would say. But most studies reporting that are looking at visual estimation because, for instance, now in the solution trial, bailout stenting was about 20%. So that would mean that you have 80% optimal angiographic results. I'm a bit reluctant to believe that. But anyway, those lesions were left alone and at the end tended to do well without stenting. I would use my common sense here. So here we knew from the ostium of the diagonal that the area was, let's say, about 1 to 1.5. We increased to 2.9, so that's a 100% gain in lumen areas. And I think eventually everything that increases to anything above 2.5 to 4.0 is physiologically relevant. And that's a threshold I would like to recommend to use. Everything above 2.5 in smaller vessels, everything about 4 in larger vessels is, at least from a physiological perspective, a significant gain in lumen area. Let's see if we have any more questions. Diagonal is quite big. FFR in the diagonal, yes, obviously that could have been an option. In this case, the flow was a little bit hampered. So in case the TIMI flow is less than 3, I would be reluctant to use physiology. Jurgen, any final comments from your side?
No, the last thing I also see that also the diagonal after this pinching often is recovering over time.
Yeah.
Probably if you don't do that, of course, but if you invite this patient after a couple of months for CT or for re-angiogram, you will see that this bifurcation also angiographically will be very completely recovered.
Yeah.
Because it was hardly any plaque you made with the DCB. You increased it a bit. Tiny, very tiny dissection in there. So I think nature will do its work now.
Yeah. No, that's a fair point. And also maybe a final comment to come back to your question on when do you do angios. With the use of imaging, we became a bit more reluctant to do a lot of angios in between every step. but also there use common sense. If the patient is stable, is comfortable, there's no chest pain, the EKG is unchanged, usually then I think the imaging already tells you a lot, and there's no need to make angios in between each of the individual steps. With that, I think, Jari, we can conclude a nice third edition of the iPCI Imaging Club. We thank you very much for watching. I would like to thank Jari for his excellent preparation. Thank Jurgen for his insightful insights.
You're very welcome.
We are encouraging you to attend also the upcoming edition. So we intend to do this monthly. There is the email address that you will find in the advertising links, which will also allow you to send in cases. If you have specific cases that you want us to discuss, please feel free to send in cases. And we have obviously our website and YouTube platform in which you are free to watch all the previous editions online as well. With that, thank you for watching, and we hope to stay connected within the upcoming edition. Thank you and goodbye.
Okay.
Thank you.